Hello, everyone. My name is Brittany Golnick, and today I will be presenting on dystonia. So before I go into what dystonia is, I want to quickly go over the brief history of dystonia. This is Hermann Oppenheim. He was a very well-known German neurologist from the 19th and 20th centuries, and he devoted a lot of his time to understanding different neurological disorders, one of those being dystonia. He wrote a paper in 1911 that where he coined the term dystonia musculorum deformans, which is now what we call dystonia. And he really laid the foundation for future work in this field and allowed other neurologists before him, before this paper, to really put together the pieces of what they were seeing. Instead of other neurological disorders, they realized that they were actually observing dystonia. And in 1929, it was categorized as a syndrome. However, in 1944, Ernest Hertz redefined it as a disease instead of just a symptom or a syndrome of other neurological diseases. It was its own. So, what is dystonia? Dystonia refers to a heterogeneous neurological movement disorder of muscle tone and is characterized by abnormal and involuntary contractions of the antagonist and agonist muscles that cause a lot of uncomfortable twisting and abnormal postures. And this is to be found with individuals at rest and during certain tasks. So it kind of varies between individuals. Here's a very short video to show you of what it looks like.
This out loud. 1, 2, 3, 4, 5, 6, 7, 8, 9. Good. Go as high as you can. Let's see what you can do. Get up really high. It's pretty hard. Let me see what you can do.
So you can see this child has a lot of difficulty with executing voluntary contractions and stopping involuntary contractions, and a lot of contractions or contractures in his hands, arms, and feet. So Grutz and Klein came up with they called it the clinical characteristics. So this is axis 1 of the clinical characteristics of, because dystonia can manifest in many different types. So they needed kind of a idea of how to diagnose and treat dystonia because there's so many different patterns, I guess you could say, that and variability in individuals. So the clinical characteristics for axis 1, this looks like the age of onset, the body distribution, temporal pattern, and associated features. So this is a figure that they had in their article, and this really kind of shows you all of the different parts. When we talk about body distribution, this is kind of how we show the different types of dystonia. So you can have focal dystonia that affects one muscle or one part of the arm or one part of the body. And this can look like blepharospasm, which is of the eyes. And then you have segmental dystonia, which affects two or more parts of the body that are connected. So an example of this would be bibrachial. It affects the whole arm. And then you have multifocal dystonia, which affects more than one body part. However, they're not related. They're not connected. This can look like cervical dystonia or hand cramp. They could have both, but they're not connected body parts. Or generalized dystonia, which affects most of the body, including the trunk. And this is normally seen with genetic mutations. So an example would be D1T, DYT1, or torsion dystonia. And then there's also hemidystonia, which is a little bit less common, but it affects one side of the body. And then we have the temporal pattern. These can be described in two different types. This is the disease course, or if it's static or progressive. And then you have the variability. Is it persistent? Is it diurnal? Meaning, does the time of day matter? Is it action specific? Things like that. And then you also have the associated features. This looks like isolation. Is it isolated? Is the only movement disorder that there is? Is it combined with another movement disorder? For instance, dystonia and chorea, or is it complex? Does it manifest in other ways? Meaning they might have chorea, dystonia, but then they also have manifestations of visual impairments or ataxia or hearing loss and things like that. So all of these characteristics really help with diagnosing and understanding how to treat dystonia patients. And moving into who does dystonia generally affect, this is part of the figure that I showed you earlier. So you can really see there's two specific time points or people that generally are affected by dystonia. So you have infancy, which is birth to 2 years old. Mostly that shows as generalized, progressive, and isolated, meaning that it is the full body, it is progressive in nature, and it is usually the only disorder that they have when they're born with it, which is very different from when you have early adulthood from about 21 to 40. This is more focal, so it stays on one part of the body and static, so it doesn't really progress, and it is normally combined with other neurological disorders. So you can see here, the child may start with dystonia in their foot, and it will most likely progress as generalized. And then if you have an adult who has cervical dystonia, there really won't be there really won't be much progression, but it will stay as cervical dystonia, and it might manifest because of other neurological disorders or neurological movement disorders they may have. And a thing to note about these is that when you're looking at early diagnosis, it's generally genetic or developmental. And when you're looking at early adulthood, normally this means that it is acquired or secondary. So what is the physiological basis of the disorder? Overall, the physiological basis involves disruptions in the normal motor control pathways of the brain and the nervous system, which ultimately affect the muscular system, specifically the areas that regulate voluntary muscle contractions, which is the cerebellum, the basal ganglia, the motor cortex. And these disruptions show as being inherited, acquired, or idiopathic or unknown. And this is also from Groots and Klein. This is their etiology axis 2 classifications. So this really shows that another way to help diagnose and treat. And not only that, but it also helps with understanding the neurophysiology and the pathophysiology of dystonia. So moving into the neurophysiology, there's a lot to talk about for the neurophysiology. I'm going to keep it pretty concise, but overall, they've found that dystonia is not only a disorder of the basal ganglia, which they've thought for a very long time. Not up until 2021, but Brugman in 2021 showed that this really isn't just the basal ganglia. It also might involve the cerebellum, which I say might, but it does involve the cerebellum, because you could really think about if it is affecting the muscle tone, that is a lot of the cerebellum, muscle tone and posture. So if you see hypertonia, that is a lot of the cerebellum, not only the basal ganglia. And there's also a loss of inhibition in multiple areas of the CNS. So when we talk about inhibition, that's really basically inhibition acts as a counterbalance of the excitatory signals and inhibitory signals of the muscles. So when you have a loss of GABA, for instance, where GABA is the prime inhibitory motor neurotransmitter, you see that there is a lot of excitatory effects from that, causing different abnormal postures, abnormal movements. They're unable to smoothly move their muscles, and those areas become overactive. And then you have the pathophysiology, which for this instance of this presentation, I'm going to focus more on the genetic mutations. So the first genetic mutations were actually found in 1997. And since then, there's actually been over around 40 more genetic mutations that they have found, which has been really interesting because it shows that there's a lot of increased findings in gene mutations, which can really help with the treatment and the overall idea of what dystonia is and how it interacts in different individuals. And like I said before, there's also a lot of neurotransmitter imbalances. And also with that, there's actually what Pana and Saga have found in 2003, which is a very recent study, is dystonia is considered to be a motor system disorder instead of just a disease of a motor structure. So originally they really thought it was just the basal ganglia that was the problem. However, more research has come out where they believe that not only the basal ganglia, the cerebellum, the motor cortex, but also the spinal cord, the nerves, the sensory, I can't think of the word, proprioception, muscle spindle, all of those are really affected in dystonia. They don't have a specific known cause, but more research is coming out to understand what really in the motor structure is, where is the problem or where this is coming from. And with all of that, you have a lot of different skill performance in dystonia. So for instance, in cervical dystonia, someone that may have a very large rotation in their neck may have trouble walking or sleeping or have visual problems, which can change the way they walk and balance. And same with walking and running. So Brandnam found that older individuals spent a lot of their time in stance phase than swing phase, which is very common also in Parkinson's disease. So that also affects how people walk, and not only walk, but also run. And then there's also a large finding in skill performance for task-specific dystonia. So you could think of that as writer's cramp. You could see in this picture, this child is having trouble holding a pencil or writing well. It's a lot of scribbles. And then also when it comes to golf. So Lenka and Jankovic, they found that, or they reported that almost half of professional golfers have a type of dystonia called yips, which is basically a inability to control fine motor movements, which is kind of overall how task-specific dystonia presents itself. But yips really is, it impedes these golfers because fine motor movements are very important for chipping or putting in those instances. So fine motor control is obviously a huge ability to perform skills well. So this is how it kind of differs in normal individuals and people with dystonia. So there are various treatment modalities. The pharmacological treatments mostly look like Botox. This is a huge treatment for individuals. You could see that this individual has a lot of contracture in their hand, very uncomfortable. And after Botox, they are able to release their hand and move it in a more relaxed way, because overall what Botox is really doing is it's working to block the release of acetylcholine to help relax those muscles and improve posture and the movement of those muscles. And not only that, but you also have oral medications. There are a lot of different oral medications that are used in dystonia. It really just depends on what type or like how it's classified and what type you have, because there's I'm really bad at saying this, but diazepams, those are going to help increase GABA and enhance the effect. So there might be more of an inhibitory effect and less excitatory muscle movements. And then you could see levodopa, which I have highlighted because that is something we saw with Parkinson's. It's used less in dystonia, but it is a very important contributing factor for some people. And not only do we have pharmacological treatments, but we also have surgical interventions. Time-wise, I won't go too far into this, but we have deep brain stimulation that focuses on the basal ganglia structure. And then we have also intrathecal baclofen, which is also an oral medication. However, in individuals with more severe dystonia, they can actually inject it into the cerebral spinal fluid. And both of these surgical interventions are normally for individuals with a more severe type. This isn't really the first go-to treatment modality, but it is there if it's needed. Okay, so we have also rehabilitation. Rehabilitation looks like it's going to be increasing over time. It's definitely, there's a lot that goes into the rehabilitation for dystonia, but there's a lot that hasn't been found or structured, I guess you could say. So when we talk about physical therapy in dystonia, we're really looking at the affected body parts and to really try and relax those muscles, retrain the affected muscles, look at gait and balance, and try to help individuals just increase their overall quality of life. And when talking about dystonia, you really can't just think of it as being treated with one modality. It is more of a multi-layer disease. Most of the time, someone's not only going to have the modality of oral drugs, but they're also going to pair that with physical therapy or antidepressants or Botox. If you only had one, then it might not be able to affect the whole disease in certain ways, if that makes sense. But having all of these different modalities is helpful because it allows someone to test different things and see what works for them and kind of layer on the different modalities so they can have a better reaction, I guess you could say, to the different treatments that they use. And very briefly, I want to talk about how there are a lot of motor symptoms in dystonia, like tremor, abnormal muscle contractions, but there are also a lot of non-motor symptoms under the surface that are generally not able to be seen, whether that's pain, fatigue, anxiety, and this is very important to treat as much as the motor symptoms for the overall quality of life of these individuals. Okay, so nearing the end, as I went through the literature, I found that the science really shows that there are so many great treatments for people with dystonia. There's a lot of advances in genetic testing, which is extremely important. So you can be able to treat these people with the specific type that they have and treat it earlier than normal. And we're really just scratching the surface with all of these new discoveries, which leads me into the future research and treatment. It was pretty hard to figure out what to put on the slide because there is so much new research coming out for dystonia and so much treatment that there are thinking of doing, whether that's the management of pain and fatigue and rehabilitation or the increase in genetic testing to catch these diseases early, whether we're figuring out, is it more of cerebral dysfunction? Is it more the striatum dysfunction, which is a part of the basal ganglia? And we need to be able to decrease sedentary behavior. We need these individuals to feel comfortable and have the ability to participate in physical activity, whether that's as an adult or as children. And not only that, but we need to be able to give Botox to everyone that is needed and not only have it given to certain individuals, but underdeveloped countries, for instance, it needs to be a well-known treatment across the world. So yeah, there's so many different things that this research is going to, and I'm excited to see what comes out next. So thank you for listening. I hope I didn't talk too fast. These are my references, and I really appreciate it. Thank you so much, and I look forward to answering all your questions.